Okay, good morning everyone. So today we will have a case interpretation session starting with this case of a 25-year-old female patient with some anomaly. And starts. What do you think is going on? First of all, what's this exam? Pelvis MRI, okay. Huh? Female patient. What's the problem with this patient? No history provided. Good job asking for the history, طبعا. This is very important, don't forget about that. What's this sequence? T2, axial, coronal, sagittal, with fat sat or without fat sat? So this is T2 axial without fat sat, showing normal urinary bladder. What else? Okay, normal bowel loops. Okay. So, what else? Okay. T2 of fat sat, coronal, showing what? So, if you are looking for a uterus, what is the best sequence to look for the uterus?
For the anatomy, T1 is the best.
Okay. In the uterus, regarding the uterus, which orientation you would like to look for the uterus?
Sagittal.
Okay, look for the sagittal. Where is the sagittal? Is there any sagittal images here? Good. You can't find the uterus.
Yes.
What about the ovaries?
Ovaries. And in T2, we see the follicles.
Okay.
High signal intensity.
You see the follicles has a high signal intensity. So do you see them here? Yes. So your diagnosis?
There is absence of uterus and ovaries.
Complete absence or agenesis of the uterus and ovaries. Okay. What?
We should look to the kidneys.
You should look exactly. You should look for the kidneys, because whenever there is a genital abnormality, you look for renal abnormality as part of what's called as, what's the syndrome? Meyer, Rokitansky, Koster, Hauser syndrome. Okay, which is urogenital anomalies. Okay, what other abnormalities are present here? Congenital anomalies, they don't happen alone. Usually they are multiple. So, what else? Look at the coronal. whatever, anything, coronal. This is axial.
corona.
And remember, whenever we have an MRI or a CT scan, we are responsible for everything in the image. Not just because she has genital tract anomaly, you should look only for the genital tract. Anything? What do you think about L5? Where is the L5? Where is it? What's going on here? What's this? This is hemivertebra of L5 with lumbosacral scoliosis. You can see them very obviously due to hemivertebra at L5, which is a segmentation anomaly. Like you can look here. Oh, no, sorry. Where is it? Where is it? Let's see in the sagittal images. You can see this is the L5 and it's not present here. See, only half of a vertebra. So this is a segmentation anomaly. Okay? Good. Thank you very much. So what do you think the presentation of this patient is? Amenorrhea, primary amenorrhea, of course. 41. This is the MRI of a pelvis, but on ultrasound, the kidneys were normal.
No.
Yeah. Okay. In case, just a second, which one? #41. Let's see. صار هواي ما سامعين صوتك. صرتي مطبق وهاي شغلات. زين. سهلة لو صعبة تريدين؟ ها؟ هم كيف ماشي انتو قلت. ماوس عندك 19-year-old, I think male patient, presented with neurological abnormalities. 19. I remember this case because we had a big debate at the time. I will tell you later. What's going on here? First of all, you have a lot of sequences. Use them all. Okay. T2 MRI of the lumbosacral or dorsolumbar spine, showing straightening of the lumbar lordotic curve. Okay, what else? Abnormal high signal intensity. Where? Are you sure this is within the spinal cord? Could it not be extradural? صوت بدأ أسمعك. شوف, your first mistake, I told you, you have coronal or axial or sagittal or whatever. Why you start commenting just by looking at the sagittal? I give you a whole meal, you take only the salad. الموس عدت. Use everything you have to get the correct diagnosis. You are driving. هلا. What's this? Sequence. What's the sequence? شبيك صرتي بانيك اتاك؟ لا ترسي ولا تستقبل شكو. سيكونس هذا شنو هو؟ مكتوب قدامك. Look here. ايش مكتوب؟ هذا T1 axial pre or post contrast؟ لا post contrast لأنه آخر سيكونس. زين كملي. عوفي الماوس، تركي الماوس، ترك. Leave it. This one is T1 sagittal without contrast. Okay? What do you see here? This is with fat sat or without fat sat, T1? Without fat sat. Showing? This is ISO or hyper intense? Heterogeneous of what? يعني hypo لو hyper لو ISO. ISO and hyper. These are foci of hyperintense signal. So let's see how these areas of hyperintense signal on the T2, are they hyper or ISO or hypo? Again hyper. So this suggests what? Could be fat or could be blood. How to confirm this is a fat or a blood? You do fat suppression, whether it's T2 or T1, it doesn't matter. Let's see the fat suppressed images. These are what? T2 fat suppression or fat saturation. Is it hyper or hypo? Huh? متى اسمع؟ Hypo. These are صارت hypo. كانت hyper and now on the fat suppression it's hypo. Indicating what? It's not, مو could be, it is fatty. Let's first dissect, then conclude. So there is fat, in addition to other things. Not only fat, there are other components. Is this epidural, يعني extradural, intradural, intramedullary? We have to localize the lesion. The lesion is at 5, 4, 3, 2, 1, 12, 11, T11, T12. Okay? So, let's go to the axial. Axial will help us know where is the location of the lesion relative to the what? To the spinal canal. This is the lesion. And this is the spinal cord. You can see here, this is the spinal cord. And this is the what? The lesion. Where is it located? Intradural. Intradural, intramedullary. Can we have intramedullary extradural?
Yes. Intramedullary extradural? No,
I'm
no,
gonna kill you now. You can never have something that is intramedullary and extradural.
Yes. Intradural, intramedullary, or intra.
If it is intramedullary, definitely it's intradural.
Yes.
Okay? If it is intradural, can be intramedullary or extramedullary. Okay? So it's intramedullary, intradural, with areas of T1 and T2 signal hyperintensities on non-saturated images and loss of signal intensity on saturated images. Now let's give contrast. Let's see what will happen. This is T1 post contrast. Did it enhance? Just a second. For even better evaluation, let's have pre and post contrast. These are pre and post. What do you think of the enhancement? This is pre and this is post. So it's not markedly enhanced, maybe mild, could be. Okay? So, what do you think is going on? What's your diagnosis or differential diagnosis? Intramedullary lipoma. What else? Intramedullary lipoma means pure fat. So all of it should be hyperintense with loss of signal, not part of it. What else? Sorry? Teratoma, which means يعني شنو؟ dermoid cyst. What's with dermoid? What's against dermoid? Heterogeneous with areas of fat signal intensity. These are dermoid, indicate يعني consistent with dermoid. Okay? So your diagnosis is spinal dermoid, which is not that rare, in fact, okay, to have a spinal dermoid. However, there is something that, as we said, these neurological things, they don't come alone. There are some other associated abnormalities, like congenital. So, there is something else that you missed. Alhamdulillah, I didn't miss. Let's see. What other abnormality? قلبي بالصورة وقولي لي what other abnormality that this patient have that you can perfectly see on the axial images? Huh? ما أدري أنت قولي لي. I don't know. You are the reporting radiologist, not me. What's going on?
Cystic lesion.
Okay.
Two cystic lesion.
Okay.
At the right iliac fossa.
Right iliac fossa.
At the left.
لا right ولا iliac fossa.
لا left. At the left bottom.
What is? Do whatever you like. What do you have here? زينب. Cystic lesion. Where? Iman. Bilateral hydrourethronephrosis. انزلي بالصور. انزلي مو صعدي. Do you see the ureter? Sorry. They are big, they are dilated. Both kidneys are hydronephrosis. These are not cystic lesions. These are renal bilateral hydronephrosis due to what? واحد عنده spinal dermoid. ليش يصير عنده hydronephrosis? Neurogenic bladder, definitely. He has a neurogenic bladder with bilateral severe hydroerythronephrosis. Let's see, do we have a coronal myelo? See this one. Okay? So you are responsible for everything in the image. Not only the... The funny thing about this patient, the story of this patient, he was imaged in a very well-known place here. Okay? And a very, well, someone very well-known reported it as spinal AVM. Could this be an AVM? First of all, no flow voids, no enhancement, no associated vascular engorgement, okay? And the cord above it is normal. And you have fat signal intensity that is suppressing on fat SAT. From where the hell did you get the idea of a spinal AVM? And surgery was done and histopathology came back to me as spinal dermoid. Okay? So you have logical steps, you go through it, and then you get the conclusion. Whenever you have مثل الأوفري drop of fat, you go to spinal dermoid. It's just the same. Sure. If you have no fat signal intensity at all, then it is much more complicated. You have to put ependymoma, metastasis, still dermoid, not necessarily to have fat in it. Sometimes there is no fat. You have to put the whole differential diagnosis of spinal masses or medullary masses. You have nothing else to go on. But as long as you have fat, it is a dermoid. Whether it's in the ovary, in the spinal cord, in the wherever. Anywhere. Lesion that is not purely fat, it's a spinal, it's a dermoid cyst. Okay? زين. هلا. سعد بيش. اوكي. وعد. قاعد بس على يوتيوب راوينا العضلات. زين. خلي لك فد شيء معدل.
معدل؟ لا خليك شيء بسيط.
اوقف. زين. هو يعني سهل بس شوية دقة ملاحظة يراد له. This is a 27-year-old female patient having some pelvic pain and pelvic problems and things like that. Go. T2 fat sat of the pelvis, sagittal image. هاي نفس السيكونس ترى. كل واحد مرتين. before filter and after filter. pelvic pain and pelvic dysregular something.
Is something abnormality.
There is some abnormality here. Was this something abnormality?
Well defined high signal intensity and the anterior wall of the urinary bladder.
Okay, at the dome of the urinary bladder
Of the
mainly.
urinary bladder. High
Cystic
signal
lesion.
on T2. Let's make it connected to the wall or extend to the umbilical or not.
Sorry?
Let's see if there is extension to the umbilicus or not.
Okay, see if there is extension to the umbilicus or not. What do you think is going on?
تحس مثل الكاثيتر.
تحسه مثل الكاثيتر. Good job. زين.
بس هاي الكاثيتر ليش راح هناك؟
It's not in the uterus, not in the bladder.
Not in the bladder.
Okay? And it's hypointense
Hypointense.
Linear on
T5.
all sequences.
Mm.
What would you like to ask the patient? He's doing it. يلا هسه طلعت العضلة. هسه طلعت العضلة. خلونا ساكتين. هسه مو راح ينزل ينزل على اليوتيوب العالم يتفرجون.
Previous operation.
No surgery. Well, some intervention.
Some intervention.
غير catheter, what else this could be? Other than catheter. زين خلينا نشوفه بالكورونال. راوينا اياه بالكورونال. شو يشبه؟ ارجع 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 ارجع. اوقف. What does this look like? ولا تحس؟ What does it look like? You've seen it a billion trillion times. Just not here.
Just not here.
Huh? يلا.
ICD?
Yes, it is. This is an IUCD,
We have no location.
extrauterine. It's dislodged IUCD in the between the uterus and the bladder, somewhere in between, surrounded by some fluid signal intensity as part of inflammatory reaction to foreign body. So IUCD can be dislodged, God knows how, from the uterus into the extrauterine location. Okay, I have one case, I've shown it several years ago. IUCD that is dislodged from the uterus and now it is intravesical. How? الله أعلم. شلون طلع من اليوترس وفات بالبلادر ما حد يدري. Okay, it's not that hard but it needs some attention. زين. Thank you. ايش قد عندنا وقت؟ عندنا وقت هواية. يلا زينب خلينا نسمع صوتك. ما سامعين صوتك قبل. ها لا قلنا فد شيء سهل. Let me see. يلا CNS 95. This is a 23-year-old male patient presented with some headache, visual disturbances, things like that. الماوس عندك و استلمي القيادة. يلا. What's the sequence?
T2.
T2 what?
Axial. T2.
أول ما تقول this is an axial T2-weighted image of the brain showing.
There is supracellular mass.
Again مطيك ستدي كاملة. ليش تورطين روحك من أول سيكونس؟ شوفي كل شيء واحكي، ما حد مستعجل، على راحتك. عندك التي 1 والتي 2 كل شيء كلاشي. راحت على السيرفي تمام. اوكي بس لحظة تركي الماوس ثانية. شوي نسوي زوم على مود شنو. just a second. يلا اشتغل. شوف التي 1 هايبوينتنس على تي 1 لو على تي 2؟ زين هذا. وعلى تي 2 شلونها؟ مو ترجعين، المفروض شفتي تي 2 بعد. Is this the same mouse? Good. صعدي. So do you think this is a hypo on T1 and T2? ISO. This is ISO intense on T1 and ISO intense on T2. Good. قبل على الكونتراست ما تشوفين ساجيتال، ما تشوفين كورونا، ما تشوفين فلير، ما تشوفين قبل اول ما شفتي ماوس قبل الكونتراست. انزلي بابا انزلي. واخري ايه. هذه شنو هذا؟ هذا تي 2 هذا تي 1 وهذا تي 2. زين على تي 1 شلونها؟ how does it look? ISO. And on T2? Heterogeneous. Mostly ISO. Okay. Is it intra or extra axial? Where does it located? Supracellular. How can you say it's supracellular? What do you need? Which sequence? قاعد شلون تقولين supracellular ذاتي ما شايف الساجيتال؟ Where is it located? يعني مو سيلر؟ سيلر لو سوبرا سيلر؟ I'm asking سيلر لو سوبرا سيلر؟ لا تفضلين تخوطين. وين السيلر؟ إذا هي سوبرا سيلر where's the cellular torsica؟ أشري لي عليه. ها؟ اوكي فهي سيلر ولا سوبرا سيلر؟ مو صح؟ او اتليست سيلر اند سوبرا سيلر اتليست يعني. خوش. What does the cellular torsica contains؟ شنو الكونتنت مال cellular torsica؟ cellular torsica شنو الاناتومي مالته؟ ايش بيها؟ اوبتيك نيرف بالسيلا تورسيكا.
ما أذكر
سيلا تورسيكا ايش بيها؟
بتوتري
اي بيتيوتري، قولي بيتيوتري. لا ليش صافنا؟ وير از ذا بيتيوتري؟
هي الماس كأنها هي البتوتري يعني
هي البيتيوتري. ماشي تمام زين. ماس بالبيتيوتري انترا اكزيال ولا اكسترا اكزيال؟ منو كان وياي بالام ار اي ذاك الاربعاء؟ البيتيوتري ماس انترا ولا اكسترا اكزيال؟ تمام. الله خلقها هيك، ايش مدريني يعني.
ما أعرف يعني هو الإكسترا أكسيال بيجي لازم سي اس اف لازم أطلب
هذا من يكون بالسيريبرال كونفكسيتيز. pituitary masses are extra axial. Okay, they are not intra axial. Google it. ماشي زين. So this is a pituitary mass. It's an extra axial. What could it be?
السايز مال الماس إذا كان more than 10 ملم
Let's measure it. Let's measure. It is almost 16. Macroadenoma or
هو السيلا وهو الساتش الديفرنشيال دايجنوستس اللي هي اول الاس اللي هي
sarcoidosis,
الاي الانيوريزم،
aneurysm,
التي
teratoma,
الاتش الهامرتوما،
hamartoma,
ساتش مو المي الام المننجوما.
okay, meningioma, optic glioma. Good. So let's give contrast and see what will happen. This is post contrast, and I think this is a pre contrast. What does it look like? Enhancing or non enhancing?
الكونتراست الفيرست
High contrast or high not contrast? So it's showing enhancement. And what is this?
هذا
Dural till. So it's a meningioma. Do you agree? Guys. هلا دكتور عليكم السلام. هسه خلصت. Do you agree guys? This is pituitary stalk. And this is a big macro adenoma in the pituitary. Could it be sarcoidosis? You should have a basal enhancement and nodularity, something like sarcoidosis or TB. Could it be aneurysm?
signal void
First, you don't have signal void. Second, aneurysm of what? These are the internal carotids bilaterally, very nicely demonstrated. Could it be metastasis? Yes, it could. Every mass can be a metastasis. Unlikely, very rarely, but it could. Could it be what else bad? Hamartoma?
thickening في الستوك يصير
Hamartoma? Not enhancing hamartoma. This is enhancing. Okay. Could it be what else بعد؟ ايش بقى؟ Optic nerve glioma?
الايج مال بيشنت احنا نحكي
23 years old. Anyway, optic nerve glioma is usually part of what? Of a neurofibromatosis, which we don't have any evidence of. And in the axial, the optic nerve was basically normal. Let's see, where is it? This is the axial. The optic nerve here looks quite good, here and here. So it cannot be an optic nerve glioma. So this is a very straightforward case of pituitary macroadenoma. Okay? Thank you very much. See you next time. Good job, everyone.